perspective. So this means what is the role of the neurosurgeon when it comes to the treatment of brain metastasis. So I'm going to start by showing this this pivotal study. It's a study from the early 90s that actually established the role of neurosurgery in the treatment of metastasis. Back in the 90s, there were two big randomized studies where surgery plus whole brain radiation was compared to whole brain radiation alone. And what was shown is that there is a clear survival benefit when you add surgery to whole brain radiation. And of course, the local recurrence rate was much, much lower. So this was great news for neurosurgeons. And from that point onward, in every guideline and every review paper, there was a statement, much like this one, that the role of surgery in the treatment of brain metastasis is essential and it is firmly established. But that was back in the 90s. And, you know, back in the 90s, people got whole brain radiation, and now they get local radiotherapy or even stereotactic radiosurgery. So all of a sudden there was, well, not all of a sudden, but gradually there was a shift in the treatment of brain metastasis, and more brain metastases were not operated anymore, but they were rather irradiated, particularly with stereotactic radiosurgery. So in the last couple of years, you start seeing statements like these ones: SRS has a local control rate comparable to surgery, and that the role of surgery, role of us neurosurgeons should be revisited. So this is exactly the point of my talk. In the era of SRS, where metastasis can be irradiated with excellent results, is there a place for neurosurgeons? Well, let me say I'm going to present you some studies, and there are many studies I could present. I chose, usually I went with the best ones. So we can all agree now that the stereotactic radiosurgery is standard of care for brain metastasis. But what about large ones? This is a very recent, well, not very recent, but this is a study from 2017 where they compared stereotactic radiosurgery alone to stereotactic radiosurgery plus surgery for large metastases. And this is a retrospective study, and only metastases with that were over 4 centimeters were included. And what was shown is that the 1-year local the local recurrence rate was much higher in case of SRS alone. That means surgery plus SRS was better in case of large metastasis. And the same with overall survival. Although it did not reach a statistical significance, we saw that the overall survival was better when the large metastasis was resected. So conclusion, gross total resection with SRS was associated with significantly reduced local recurrence compared with SRS alone for large brain metastasis. So what is the very first take-home message? First of all, we can kiss the small metastasis goodbye, but there is definitely a role for large metastatic lesions. Now, what about how we operate? Does it matter how we do it? We know, for example, that in glioma surgery, taking the whole tumor out plays an important role when it comes to the prognosis of the patient. But what about metastasis? Well, in this retrospective study, they saw this. This is a very, it's not a big study, but it has a great follow-up. And it was clearly shown that gross total resection had a significant survival benefit over subtotal resection. And this is another study. It's a big one when it comes to the number of the patients. And what was shown is that not only it matters if we take the whole tumor out, but the way we take the tumor out matters also. So in this scenario, they compared en bloc resection of the metastasis versus piecemeal resection of the metastasis. And what they saw is that the local recurrence rate was much lower. This is proportion without local recurrence, much lower when the tumor was taken out en bloc versus in a piecemeal fashion. And another study, again, from 2009, with lots of patients, 827 patients, where surgery was compared to SRS. And again, it was shown that if the tumor was taken out in a piecemeal fashion, the leptomeningeal metastasis risk went up. So how we take a metastasis out is definitely important. We should take the whole tumor out, and we should go for an en bloc resection if this is possible. Now, a common misconception I keep hearing about is that metastases are easy tumors. Let the resident do it. It's an easy tumor. It's got clear boundaries. But this is nothing could be farther from the truth, because here you can see in this study from 2015 that the brain infiltration was almost 50% regardless of the time of the tumor. Particularly in some cases, such as rectal and small cell carcinoma, this rate was even higher. So it's very important that you don't leave anything behind, and it's very important that you identify the margins of the tumor, because not only is it not very easy to operate, but it also plays a very important role when it comes to overall survival, whether the brain infiltration is there or not. Now, are there any tools that can help us with our resection? How about intraoperative ultrasound? Please forgive this video. I just took it today out of my own PC, and this is a combination of intraoperative ultrasound combined with MRI and navigation and tractography. So intraoperative ultrasound is a great tool to help you detect residual tumor and to visualize the metastases. And there are some studies that have shown that that ultrasound is a very useful tool. Today, there was no clear evidence on overall survival. What about fluorescence? Well, I'm a big fan of 5-LA for gliomas, but for gliomas, 5-LA has shown that it's not really useful. There was only 66% 5-LA exudation in brain metastases. And even in cases where there was a visual fluorescence, this was very heterogeneous, and in many cases, it was shown that the surrounding brain tissue was also emitting fluorescence even after gross detection. So 5-LA is not a great option for metastasis, but the green dye, the green-yellow dye, sodium fluorescein for brain metastasis, it seems to have much better results, and it helped with lower residual tumor volumes and low risk for local recurrence in this great study from Innsbruck from 2023. I've included here a fun fact. In this study, the surgeon was asked right after surgery, do you think you got the whole tumor out? And the response was, yeah, I got the whole tumor out in 95% of cases. But the MRI the next day revealed that this was only the case in 72%. So every time a surgeon tells me I got the whole tumor out, I'm a bit reluctant to believe it. I'm just going to wait for the MRI scan of the next day. So the second take-home message is, well, first of all, large metastatic lesions, we've established that. And the second is Gross total resection should be the goal, and if possible, it should be done en bloc. Now, what is the role of surgery in multiple brain metastases? There is no class 1 evidence, but this is a very recent study from 2020, where in 750 patients, 50 of them had multiple metastases. And in those patients, the symptomatic one was resected. And what was shown is that when the symptomatic metastasis was resected, there was a significant improvement in the clinical status, and this led to greater chance to receive adjuvant treatment and to a greater overall survival. So, what is the role of surgery in case of recurrence or radiation necrosis? Because, I mean, we know that stereotactic radiosurgery is a great tool for small metastases, but it does carry a risk of recurrence and of radiation necrosis of up to 20%. And once you've irradiated the tumor and you see this contrast enhancement building up again on MRI, it's not very easy to tell, is it radiation necrosis or is it recurrence? The second problem is that even if you know that it's recurrent, it's radiation necrosis, sometimes these patients have very persistent brain edema. And sometimes if you talk with their oncologist, he says, well, you know, he's on steroids because of all this brain edema due to his radiation necrosis, and I can't give my patient immunotherapy. Before I proceed to the surgical treatment, I wanna present you with a small teaser. There is emerging evidence that bevacizumab, Avastin, helps with the treatment of radiation necrosis and edema. And this is a recent case from the wife of a colleague of mine. She had radiation necrosis, she had lots of edema, and this is after the last session, well, after the first session of Avastin with significant build down of the brain edema. Coming back to the role of surgery in case of recurrence or radiation necrosis. This is a retrospective study with 58 patients that recurred after stereotactic radiosurgery. The interval between stereotactic radiosurgery and surgery was only 7 months, and the postoperative local control after surgery of the recurrence was 62%. An important prognostic factor was the time interval between stereotactic radiosurgery and recurrence. That means in cases where the tumor came back very early, within 3 months, then no matter if you operated or not, the prognosis was rather bad. So this is another study with from 2020 with salvage surgery for local progression after stereotactic irradiation. 48 patients with disease progression. Again, the local control rate after surgery was 76%. Great quality improvement in quality of life. You see here, this is the Karnofsky score in blue before surgery, and most patients had a Karnofsky of 50 and 60, and these patients improved significantly to 70 or 80. This is a study from my Cologne days, where we actually operated on the symptomatic brain metastasis of a very, very, aggressive tumor cancer, which is esophageal cancer. And what we saw is that resecting the brain metastasis did not improve overall survival, but it did significantly improve the quality of life in these patients. Another option for us neurosurgeons in case of recurrence or radiation necrosis after SRS is in deep-seated brain metastasis, where the metastasis has already gotten stereotactic radiosurgery and it's not a good candidate for surgery. You can use the laser, the LIT option, which is the laser interstitial thermotherapy acronym. And it's actually an implantation of a stereotactic of a catheter, and you use thermal damage to control the tumor, and it can be greatly combined with the robotic arm from Medtronic. It's a great option. This case where you see this is the metastasis with gadolinium, and this is after treatment where the contrast enhancement is significantly lower and the edema has also subsided. So what does the future hold for us neurosurgeons? Well, we know now that the brain metastases have a molecular signature that may differ from the primary tumor. That means as more and more immunotherapy options and personalized treatment options are going to become available, sampling the metastases for molecular profiling is going to be needed. So probably in the future, you are going to see much more biopsies for brain metastases just for molecular profiling. And I'm going to close with two cases. This is a patient that came with brain metastasis from lung cancer. He had two big metastases, as a big cystic metastasis in the posterior fossa and the smaller one on the frontal lobe on the left. And what we did is we discussed with our colleagues, and we took this tumor out. It was not a very good candidate for radiation treatment, and this metastasis was actually radiated with great results, and this is 4 years ago. And this is a second case with two metastases, one smaller, very close to the hand region of the central area, and the one very close to the foot region, and both metastases were actually irradiated with stereotactic radiosurgery. The smaller one responded very well. The larger one developed significant radiation necrosis with brain edema, and we went ahead and we operated this patient with very, I think, good cortical and subcortical mapping, and the result was great. And 21 months later, this metastasis also showed a delayed radiation necrosis, and this metastasis was also operated. So the take-home message is neurosurgery may not have the role that it had a couple of years ago, but there is significant role still in large metastatic lesions. Gross total resection should be the goal if possible in block. Resection of symptomatic metastasis improves the Karnofsky performance status, and in case of recurrence and radiation necrosis, it also offers good local control. And I may add a fifth one here. In the future, there's going to be a need for molecular profiling of the metastasis. Now, of course, as a closing remark, you may or may have not noticed that almost all of my studies were retrospective ones. So the data regarding brain metastasis is rather poor. You have level 3 evidence. There is a significant selection bias. If you ask me, I'm going to say, yeah, let's operate because neurosurgeons want to operate. But then again, I mean, radiation oncologists, they want to irradiate. So I guess that makes us even. And I think it's very important. I'm going to keep saying that we establish functioning towards where these kind of patients are going to be discussed. Thank you.